Hello, I'm Professor Patrick McGorry. Welcome to today's webinar. Before we proceed, as Executive Director of Orygen, I would like to acknowledge the traditional custodians of the land on which we work around Australia and pay my respects to elders both past and present.
Hello and a warm welcome to everyone joining us in today's Service Development webinar, proudly hosted by Orygen, the National Centre of Excellence in Youth Mental Health. My name is Jonah and I'll be your youth convener today. As a former intern here at Orygen, my eyes are really open to the challenges that confront today's youth, but what I really admired was the passion that professionals within the youth mental health space demonstrated in improving services provided. Therefore, I'm a huge fan of everyone with an interest in youth mental health, and thank you for participating in our webinars. To start us off, please welcome our first presenter, Heather Staveley. Heather is an Associate Director of Service Development in National Programs at Orygen. Heather has extensive clinical and service development experience. She has a strong involvement in the implementation of Headspace early psychosis programs across Australia. Heather has been responsible for the program management of several large national projects with a focus on upskilling the youth mental health workforce and service development activities. Heather has presented at both national and international conferences and has been involved in knowledge translation, webinars and workshops, and has authored and contributed numerous clinical resources. Heather, thank you for joining us today. I'd really love to know more about the current challenges that face professionals in youth mental health care and some of the emerging trends that we're seeing in service development.
Well, that's great, Jonah, because I will very shortly be talking about those as the challenges are very important to look at.
So what does this all mean in general terms?
So I suppose just to sort of start off, in this webinar today, we're basically going to give you an overview of the issues in youth mental health and consider what the evidence suggests may be best practice models, particularly in the Australian context. This may seem simple, however, there are many complexities and elements to consider. And as Jonah has already recognised, there's always been challenges in addressing mental health needs. And these challenges include developing a sufficiently trained mental health workforce, defining the type and need of care required, as well as what type of workforce you need, enabling appropriate service provision, and addressing the problems of societal stigma. So just to look at the challenges a little bit further, they are present for any age group, but are particularly pertinent in young people as mental health problems are so common and often initially arise in this age group. So mental health problems represent the largest burden of disease in young people. One study says that 50% of mental health disorders first emerge by the age of 14 years and 75% by the age of 24 years. A Australian National Mental Health Survey data also has revealed that the youth age band has not only the highest incidence and prevalence of mental illness across the lifespan, but they also manifest the worst service access of any age group. And added to this are the particular developmental challenges faced by young people in the adolescent and early adult age range when independence, personality and life direction are all being established. There's also a question of where and how youth mental health care should be provided. Traditionally, mental health care has been provided within state government public health settings. However, in more recent times, there's an increased role for primary care in responding to mental health concerns, which have been recognised and supported in particular by Australian federal government initiatives. Provision of youth mental health services within primary care has the potential to massively increase the numbers of young people who can receive help and achieve improved outcomes. It also has the advantage of being less stigmatising, more accessible and more recovery focused than the state-based tertiary or specialised care settings, who are often dealing with the more acute and highly at risk young people needing mental health care. So for the moment, let's think about the specific needs of young people. The term adolescence is now used interchangeably with the term youth and generally includes the age range from 12 to 25 years. The term emerging adults has been introduced to highlight the prolongation of the period prior to the achievement of complete independence that has occurred over recent decades. In the complex modern society, it is common for the tasks of finalising education, commencing careers, establishing intimate relationships, and engaging in the adult world to take place over many years. So there's been one author, who's Arnett, who has described emerging adulthood as the in-between stage, or in-between age, encompassing the end of adolescence and the transition to young adult responsibility. Basically it talks about 5 components, and I'll just briefly explain these. So, age of identity exploration, that is when young people are deciding who they are and what they want out of work, school and love. Age of instability. This is the post-high school years, which are marked by repeated resident changes, or can be marked by this, as young people either go to university, TAFE or college, or live with friends or a romantic partner. For most, frequent moves end as families and careers are established in the 30s. Age of self-focus. Freed of the parent and society-directed routine of school, young people try to decide what they want to do, where they want to go, and who they want to be with, before those choices get limited by the constraints of marriage, children, and career. Age of feeling in between. Many emerging adults say they are taking responsibility for themselves, but still do not completely feel like an adult. The age of possibilities is the last one, and this is where optimism reigns. Most emerging adults believe they had good chances of living better than their parents did, and even if their own parents divorced, they believe they'll find a lifelong soulmate. So adolescence, or emerging adulthood, is therefore a prolonged and complex developmental stage that presents many challenges. And as you can imagine, these challenges are magnified by the presence of mental ill health, and so need to be considered when developing any type of service culture, structure, and the type of delivery model for youth mental health services. As noted in the previous slides, despite having the highest need for mental health care, emerging adults have the worst access to mental health services and therefore the greatest unmet need. This is in part due to structural issues in mental health services. Traditionally, the provision of mental health services has been divided into child and adolescent, treating those up to 18 years of age, and adult for those over 18. The transition from child and adolescent to adult mental health services is extremely disruptive to effective mental health care, as it imposes an arbitrary care gap where young people are discharged before age 18 and may not meet eligibility criteria for adult services. This is inconsistent with the biopsychosocial trajectory of mental illness. As noted, over 75% of mental illnesses emerge before the age of 25. The traditional approach of using the age of 18 at the point of demarcation between services for children and those for adults undermines the need for continuity of care at a time when young people are at their most vulnerable to mental ill health. One study showed that 1 in 4 young people experiencing mental illness had only 30% were actually seeking help. Previously, Professor Hickey has reported that 70% of young people with mental health issues were not seeking or receiving professional help. Of these, many are not referred to adult care, drop out, or are not accepted, meaning there is a gap in the service where it is most needed, such as the 16 to 20 years age group. And of concern is that mental ill health also exacts a substantial burden of mortality in young people, with increased rates of suicide in young people experiencing mental illness. This is very concerning. In addition to the traditional age-determined service divide, a number of other factors are thought to contribute to the poor access by young people to mental health services. These fall into 2 categories: features of young people and characteristics of services. I will just briefly explain both of these. So young people are typically healthy and can believe they are invulnerable and thus have very limited experience of health services and help seeking. Therefore, they often do not know how to seek help or even that it is available. for their particular concern. Being more peer-focused makes them more likely to discuss issues with friends and so to shy away from adult professions. The significant developmental changes of this life period, if you think about what we were just talking about in terms of the sort of 5 stages of emerging adults, it spoke to some of those. It also includes cognitive, such as thinking, social, physical and emotional development, can make it difficult for them or others to notice mental health issues or recognise the need for care. Then the second point, in terms of features of services, often present barriers to young people seeking help. Location and cost can limit access. Complicated referral pathways and waiting lists based on eligibility criteria and assessment protocols prevent many people from receiving appropriate treatment. Finally, uninviting clinical facilities filled with seriously unwell adults are not so attractive to young people and are unlikely to encourage their help seeking. Hence, there has been an approach to address these areas with a more youth-friendly and early intervention approach. So we'll now try and look at some of these solutions and examples. In order to address the specific needs of young people with mental illness, Orygen in 2007 proposed a population-based youth-focused model, explicitly integrating mental health care with other youth health and welfare expertise. It was seen that addressing young people's mental health needs was crucial to fulfil their potential and contribute fully to the development of their communities. So fully integrated youth mental health care has been described as the joining up of primary mental and physical health care services with social care so that services are organised and coordinated around the needs of the individual. It is suggested that young people who receive integrated care have improved mental health outcomes. Particularly integrated youth health care has been seen as a solution to the problem of poor access by young people to mental health services. As just noted, prior to 2008 in Australia and in other countries, there have been the same arbitrary gap in service provision, such as, say, for example, Canada. Young people have had the worst access to mental health care of any age group across the lifespan, despite comprising the primary onset period for emerging mental illness. Thus, as we've talked about already, the traditional service configuration of child and adolescent and adult mental health service is considered an impediment. One author, Miller, in 2016, listed the problems that stem from this as being 1. Poor access rate of services for the youth. 2. High rate of untreated prevalence, so young people not seen for treatment. 3. A delay in first contact and treatment. 4. Treatment not always suitable for that particular stage of illness. And finally, transitions between services based on age, usually 18, leading to service gaps. So to address some of these challenges that have arisen, the concept of early intervention in youth mental health, which has been strongly promoted in Australia, so arising initially from the work in the early psychosis field, and it has gained momentum in many other countries. So early intervention is the early diagnosis of potentially serious mental health disorders and those at risk of developing a disorder to prevent the progression of ill health and also not only to minimise functional impairment. So a preventative and recovery focus is also embedded in the Australian government policy at both state and federal levels. It is seen as not only critical for preventing or reducing the progress of mental illness, but also for improving a person's mental and physical health, community participation and long-term socio-economic outcomes. So over the past 20 years, there has arisen an increasing understanding and focus on youth mental health care with the concept of early intervention, prevention and recovery. As I've said, it's arisen mainly from the work in the specialist and severe mental ill health field of psychosis and schizophrenia. So it has been the combined clinical and research work of Orygen Youth Health and Orygen and also work elsewhere, both in Australia and internationally. In terms of Australia, So EPIC, known as the Early Psychosis Prevention and Intervention Centre, was established in 1992 to provide a service to those young people aged 15 to 24 years who had developed a first episode of psychosis, and it became the early prototype for youth mental health services. Research work, clinical practice guidelines and core competencies were established over the years, with a concerted focus on early intervention, prevention and optimism regarding recovery, along with the goal of returning a young person to their sort of developmental trajectory, or where you'd expect them to be for their age, such as returning to school or work, and it had no real aim to avoid long-term chronic disability. The early psychosis movement has spread both internationally and across Australia with the establishment of specific early psychosis services, for example in the UK, Canada, USA, Denmark, Ireland and parts of Europe. In Australia, there's been support from the federal government to establish youth-focused early psychosis programs within the primary care setting of 6 designated Headspace sites, and this is still progressing. They're known as Headspace Youth Early Psychosis Programs. The establishment of these services has been a unique situation where specialist mental health care has been offered for the first time within primary care setting. So the establishment of the Headspace National Youth Mental Health Foundation Centres within Australia in 2006 saw a shift in youth mental health care that broadened the range of mental health issues seen. So it was by enabling access for young people with mild to moderate mental health issues and other health issues such as substance use, physical and sexual health problems and vocational issues. The Headspace Centres have been described as one-stop shops for young people and as a way to respond to their special cultural and developmental needs. At the primary and community level, Headspace aims to provide better access, improved engagement and enhanced multidisciplinary care for young people across Australia. Evaluations of the Headspace model have been positive, attesting to the success of the model. Similarly, developments overseas have seen the specialised targeted youth mental health model implemented with similar successful outcomes.
To give me a better picture of how we can apply these principles in real life, can you give some examples of models of care and practice?
So just to give you some examples of youth mental health services internationally. So, there's more than one but in the United Kingdom, particularly in Birmingham, a service was opened focusing on resilience, prevention and early intervention, and they were aiming to improve access to young people so that they could have effective support, and they were targeting care for the most vulnerable. They also wanted to make sure that they were being accountable and transparent within their own system, and they had a workforce capable of delivering such a service. This service provided high quality initial assessments and reported lower dropout rates from other services this was relative to other community mental health teams. In terms of Ireland, Jigsaw, what's previously known as Headstrong, was Ireland's first specialised youth mental health organisation. It developed and implemented community-based mental health support structures for young people, and in the 10 years of their operation, they have assisted over 15,000 young people. In Canada, the Adolescent Young Adult Connections to the community-driven, early strength-based and stigma-free services, now known as Access, is a recent scale-up and transformation of a model of service delivery across Canada. Similar to the EPIC and Headspace charters, the 12 early intervention services aim to promote early identification, quick access for assessment, continuous service across the 11 to 25 years age range, and if required, connection to specialised services. In Singapore, an early psychosis service known as EPIC is a comprehensive, integrated and patient-centred program led by a multidisciplinary team of psychiatrists, psychologists, case managers, social workers, nurses and occupational therapists. The aims of the program have been to raise awareness of and reduce stigma associated with psychosis, establish links with primary healthcare providers, and collaborate in the detection, referral and management of those with psychosis, and improve the outcome of their patients while reducing the burden of care for families. An evaluation of this service reported that after 2 years, young people had achieved symptomatic remission and had returned back to school or were gainfully employed. And in 2008, the service was expanded to include a clinic for those at risk of psychosis. Similarly, integrated early intervention clinics, closely aligning with the EPIC model and youth mental health model, are achieving success in terms of engagement and treatment in the USA and Italy.
Wow, it's great to see that globally there are so many organisations invested in effective models of care. Are there any overarching principles that may contribute to the effectiveness of these models of care?
So let's step back for a moment and think about principles of youth mental health care. As youth mental health care has developed and become established around the world, there are basically core principles that have been identified. So we'll just explore these a little bit further currently. Early intervention and prevention. So I mentioned early intervention before. This basically involves a strategy that talks about early detection and assessment, and in the early psychosis field, the aim was to reduce the duration of untreated psychosis. So in other words, try and pick up young people who may be unwell in this way as early as possible, because we know it improves outcomes if you do that. And that many research studies have demonstrated that with early intervention there are, as I say, improved outcomes, particularly when the length of time to access is reduced, and it also can be expanded to all of mental health issues, so not just early psychosis work. The main aim of early intervention is to be preventative in approach, to reduce the impact of the mental ill health on the young person and their family, and to lead us to a speedier recovery that allows the young person to return to their usual way of functioning or their usual developmental trajectory. Another principle is a youth-friendly service and focus. So this basically refers to the organisational culture, such as reflected in the attitudes and behaviour of people and the staff in being welcoming, and is also reflected in the organisational setting in terms of decor and physical location, particularly with close public transport accessibility. Ease of access to expert care. This is enabled by the responsiveness of the service structures and clinical referral pathways that provide easy access and streamlined care so that young people can be seen quickly and easily without having to contact multiple services and being quickly informed about where to get assistance. There is a spirit of hope and optimism which is embedded within the service, and an aim is to return a young person to their usual improved level of functioning appropriate for their age. There's also a holistic biopsychosocial approach to clinical interventions that have a recovery focus that takes into account the developmental stage of a young person, the clinical phase or stage of the illness, the severity of the illness, and the young person's personal goals. The service approach is comprehensive, flexible and integrated, where a range of interventions can be offered to young people and their families based on the needs of the young person. Evidence-based clinical interventions are provided as best practice and can cater to all specific groups. All aspects of the service are family-friendly and inclusive in all aspects of treatment and care. There is a continuum of care approach where mild, moderate and severe ill health can be addressed within an integrated service system that is easily accessible. Community awareness and education is provided in order to reduce stigma and enable appropriate access and care for the right service at the right time. Strong youth participation is promoted and incorporated where young people are involved in service design, governance and all aspects of the service provision within the development of a peer workforce. So these principles are being adopted for youth mental health services provided in primary health settings. A youth mental health model cannot be discussed without thinking about the broader systems of care, whether this be in primary or tertiary, and can include the concepts of continuum of care, step care, and clinical staging. So just to explain these concepts briefly, a continuum of care approach can be seen as on a spectrum where young people can access a service which will respond to what mental health needs or diagnosis they have at any particular point in time and along a spectrum based on mild, moderate or severe. Young people need to be able to access a service and receive appropriate interventions along a continuum. This in turn can include a step model of care approach where while the service system wants to provide a continuum of care for a young person, decisions about treatment options and progress are monitored and changed based on effectiveness and need. There's also likely a need to match the intensity and mix of services to the need of the young person. For instance, a young person may require additional support outside their mental health concerns, and others may require a more comprehensive specialised approach such as case management involving evidence-based clinical interventions. So any model of youth mental health care for a young person needs to meet the developmental, psychosocial and their mental health needs and to be at the centre of care. Also, they are surrounded by a system of family, peers, community, cultural, educational, vocational, legal, health and other governmental systems. So any best model of care cannot be provided without consideration of the broader social context and organisational structures. When a young person becomes unwell, the major issue is firstly understanding what may be happening and where help can be obtained. They and their family are not usually going to know where they can access or what they have in terms of a disorder such as mild, moderate, severe, or whether it's acute. It is the service system and the operational models of care that can determine this, but to do so in the most accessible, appropriate and streamlined way for not only assessment purposes, but basically, more importantly, for a timely, responsive, best treatment options that meet the expectation of receiving the right and appropriate care at the right time for the young person and their family. Mild, moderate and severe mental illness is usually defined in terms of not only intensity and number of symptoms, but also in terms of impact on a young person's functioning, such as their age-appropriate behaviour, and concerning things such as their ability to self-care, attend school or work, interact with peers and others. For instance, a young person may have some mild symptoms of depression, such as lower mood and motivation with possibly some poor sleep, but they may still be attending school. There may be a small change in, say, their assessment grades, and they may still be engaging in activities, however, maybe not experiencing as much enjoyment. So an ongoing assessment with a young person will continually be assessing these areas, such as their symptoms, their attitude, their motivation and functioning, along with any risks around self-harm or suicidal thoughts or actions, and then working out the best treatment approach to match the level of illness. So, a continuum of care approach is a concept involving an integrated system of care that guides and tracks patients over time through a comprehensive array of health services spanning all levels of intensity of care. However, this is not to say that a young person starts at one point and continues down the line, say from mild to severe mental ill health. This may occur, but it can also be the reverse, or where a young person may be dipping into a service and receiving treatment at whatever level or frequency is required for however long and then moving out of care. One way of conceptualising mental health illness and incorporation into models of care is to look at the Stepcare and clinical staging models. You may have heard of the Stepcare approach, as this has been introduced by the federal government as part of their mental health reform. Stepcare is defined as an evidence-based stage system comprising a hierarchy of interventions from the least to the most intensive and matched to the individual needs. While there are multiple levels within a Stepcare approach, they do not operate in silos or one-directional steps, but rather offer a spectrum of service interventions. Clinical staging can be used alongside the Stepcare model to provide comprehensive guidance on which interventions should be provided to young people, at what time and in what way. Staging adds to the Stepcare model by allowing for matching of the needs of young people experiencing potentially significant levels of distress and functional impairment, but who might not meet the threshold for a mental disorder, with appropriate interventions aimed at both the presenting problems and preventing progression towards a more serious illness. It is a useful concept or model in youth mental health to facilitate the selection of appropriate treatments. So clinical staging is basically a framework that has been developed to assist in the identification of appropriate interventions given the extent of progression of a mental illness. Originally utilised in other areas of medicine, clinical staging has been more recently applied to youth mental health in an attempt to guide treatment selection across the range of mental health difficulties that a young person may present with, including early or mild symptoms which may not reach threshold for a diagnosis. This makes the model particularly useful for young people who often present with symptoms that are below the threshold, but who nevertheless experience high levels of distress and impairment in their functioning and so still may need assistance. As you can see on the slide, the clinical staging model uses a combination of help-seeking symptoms and functional information to categorise a mental health problem into one of 6 potential stages, ranging from stage 0 or not, which is at risk but no symptoms, to stage 4, which is basically severe, persistent or unremitting illness. For young people with severe and complex presentations in primary care setting, most would be expected to fall within stage 1B, which is subthreshold symptoms, or stage 2. Determining the clinical stage of a young person allows better matching of the intensity of the intervention with the level of need and improves safety and efficiency by ensuring that interventions with the least risk and requiring the least time and resources are offered before more intensive, invasive and costly interventions. So we've briefly mentioned here service systems. So this is really just to get you to think about a few considerations. So as we've said, often meeting the mental health care of young people cannot be met within one service or program, but within several services or organisations, and also as a way to meet a diversity of needs. The King's Fund in the United Kingdom put it well when they say, and when they were considering new models of care and principles, stated that relationships and networks should be built with a variety of partners, not only those delivering their National Health Service funded services. Key partners include social care, housing and voluntary sector organisations, as well as employers and the education system, all of which can play an indispensable role in relation to mental health. So through bringing together parts of the wider system, new models of care can capitalise on the full range of assets in an area. The recent federal government funding for youth severe or complex youth has been a way to provide services in primary care for those young people who may not be seen as requiring or able to access tertiary level of care, but who have some complex issues that may require some longer term treatment focused on engagement and possibly outreach services, but also to provide a holistic approach to their service provision. So service systems need to work together so that a youth mental health model of care will allow the unique needs of young people to be met, and for this model to be based on the principle and philosophy of early intervention, prevention and recovery. There is a paucity of evidence pertaining to appropriate service models for young people, yet we do know service systems need to work together to provide fully integrated care if best outcomes are to be achieved. To conclude in our thinking, we will talk about elements of care, but I will hand over to Shona Francie for this.
I'd now like to present our next speaker, Dr. Shona Francie. Dr. Shona Francie is a clinical psychologist here at Orygen, currently working as a clinical educator. Shona has more than 30 years experience in public mental health, mostly in the field of early intervention for psychosis. She has been involved in the establishment of both the Early Psychosis Prevention and Intervention Centre, also known as EPIC, and the PACE Clinic at Orygen Youth Health.
Okay, thanks to Jonah and thanks to Heather for an excellent overview, a very comprehensive presentation of the issues in youth mental health and models of care in youth mental health. I've got a very short little bit at the end here, which is really just a bit of a summary and conclusion about what we've heard already today. And it's going to be from the perspective of service providers. So what are the elements of care that service providers need to think about when they're developing a youth mental health service? So first and foremost, we've heard a lot about the problems of access, that young people aren't accessing care. So in order to deal with that, we really need to have services focus on active engagement, and if at all possible, a mobile outreach component to the service will really help with that. So services need to be flexible about when and where and how they connect with young people. It's also important for services to consider eligibility criteria. They need to think about whether there will be any particular eligibility criteria, and also to make sure that these are well known in the community so that young people get connected to the right service at the right time. We've also heard about the importance of comprehensive assessment. So assessment needs to be comprehensive and ongoing. It also needs to be engaging, and it needs to cover all the different aspects of a young person's life so that the most appropriate treatment can be provided, and that might well be something along the lines of an educational intervention or a vocational intervention. All of these things are really important to young people's mental health. Workforce, of course, is extremely important. So in establishing a mental health service, the service providers need to think about who's going to constitute their workforce, and how is that workforce going to be provided, where are these workers going to come from, and how are they going to be trained and have ongoing professional development to maintain the standards of care. We need to think about what roles are going to be done by the particular service. Is it a case management role? Are we looking at a peer workforce? Do we need youth workers? So it's important to think about what the service needs in terms of workforce. We also need to think about the blending of specialist and primary care. So services need to be able to provide specialist care when it is required, so when there's a serious level of mental ill health. And we need to adapt to the type of care needed for the young person in whatever is and wherever is the best setting to provide this for the young person. Also, we're wanting our clinical interventions and our functional recovery to be absolutely top quality. So any model needs to ensure that the best evidence-based clinical practice is provided, and this will usually involve a component of psychological treatment, along with a focus on supporting a young person's overall physical, social and vocational functioning. Another issue that's important to be considered in setting up a service is the issue of caseloads, or the number of young people that the service can see and still be able to provide a high quality service. So this is certainly something that needs to be considered, and I guess an example that we often talk about is about 20 young people being a caseload for a full-time clinician, but it's certainly something that each individual service needs to consider, as well as duration of care, which is the next point on the slide. So the service needs to consider and to advertise whether there are any limits to the duration of care that can be offered, and whether this will be related to any particular assessment or needs that are present in a young person. Medical care also needs to be available when it is required, and a service needs to either, I guess, employ medically trained, psychiatrically trained staff, or to develop a strong pathway network of services so that the medical care is available when required by young people. And the last point on the slide is youth participation and family participation. So we see that as really important, that there's active participation of young people and families in their individual treatment, but also for there to be input from families and young people into the design and operation of the service, so that the service remains relevant and effective for the people using it, the families and the young people. So finally, as a summary, throughout this presentation we've discussed some of the history and the development of a youth mental health model of care. This is ongoing work, and it's a relatively new field, so more research and development is required. But we've seen that any youth mental health model requires a flexible approach where young people can enter and exit, re-enter and receive treatment that best meets their needs in a timely and responsive manner. So a good catch cry for that is right care at the right time and in the right place. And we've also seen that it's really important that young people are involved not only in decisions about their own care, but also to have young people at the centre of policy making, defining service systems and developing models of care. Thank you.